this is much more informative and kind of conceptual. So why should we do nephron sparing surgery, and why should we continue and try and do it with a robot? So why nephron sparing surgery? We have now data that we didn't have about 5 years ago. Although we operate on more and more patients with RCC at an earlier stage, RCC mortality stays unchanged. The radical nephrectomy results, radical nephrectomies result in increased rate of mild to moderate renal failure in RCC patients. And we know now that renal failure leads to increased cardiovascular events and death. And compared to nephron sparing surgery, patients that undergo radical nephrectomy are faring much worse with regard to overall survival. And this is something that was not in the textbook, and we didn't realize it until just recently. And I'll give you all the robust data that we have about this. So this is from Sloan Kettering. The size of tumors they're operating on decreased from 1989 till 2005 sequentially. And they do surgery, I mean, all of us, but this is just the data were good. We do surgery in smaller and smaller and smaller tumor as time goes by because of the early detection with the CT scan and ultrasound right and left. This is a very interesting study that shows that the increasing detection of all tumors, but especially those between less than 4 centimeters, is very, very significantly increasing. So the black lines, both of them are 2 to 4. This is 2 to 4, and this is 0 to 2 centimeters, is increasing rapidly through the years, the detection of these. And at the same time, renal surgeries are increasing also most rapidly for tumors between 2 to 4 centimeters. Not so much for the below 2 centimeters, not so much for those above 4 centimeters. The main group that we do more surgeries on are patients with 2 to 4 centimeter tumors. Interestingly, at the same time, the cancer-specific mortality remains the same approximately, or climbs a little bit for all these groups, gradually climbing cancer mortality from RCC. But if you look about overall mortality, this is exponentially growing in the group that is 2 to 4 centimeters and slowly keeps going up for everybody else that we do this surgery on. And the question is, why? What are we doing wrong here? We operate more earlier. What's going on here? So this is a study done by the group from, again, Sloan Kettering. It was published in The Lancet, that looked at the patients that had 4 centimeters or lower tumor. That's the group here. It doesn't show perfectly. And how they did long-term with different modalities. The first thing that was interesting is that right off the bat, when somebody comes with renal cell cancer, 26% of these patients, a quarter of the patients presenting to you, will have mild renal failure already. And all you can do is reduce it even more, below 60 GFR. And if you do surgery, either a radical nephrectomy or a partial nephrectomy, you're going to throw these patients who started with normal GFR, 90% of them that had a radical nephrectomy at 10 years will actually have renal failure, defined by GFR less than 60. And less than 50% will have it if you did nephron sparing surgery. If you take a less strict criteria, actually a more strict criteria for GFR reduction to 45, it's a little better, but still the radical nephrectomy patients are thrown down to a significant renal failure by doing a radical nephrectomy. So we have proof here that we are causing a lot of renal failure in these patients. And this is data from the internal medicine, JAMA, from New England, that shows that the lower the GFR, the higher the likelihood of having death, cardiovascular events and hospitalizations. It correlates directly to the GFR that these patients have. And what the group from Mayo Clinic did, they said, okay, let's look at our patients. What happened, same size of tumor, if we do a radical versus a partial, what will happen to these patients? And what they found in 327 patients, that if they did a radical, the 10-year overall survival was 82% only. If they did a partial, it was 93%. And they compared these patients for all comorbidities during this study. The group from Sloan Kettering said, okay, let's look at a bigger group. And they looked at almost 3,000 patients and saw who got a radical and who got a partial nephrectomy, and this is the ratio. And what they found is that the overall mortality and cardiovascular events was significantly higher in those that had a radical procedure. And here you have the actual data. It's very significant. If you're getting a radical versus a partial, your likelihood of death is significantly higher. Same thing was shown when the group from Cleveland Clinic looked at their data, and they showed that when the post-operative GFR reduced significantly, they again, in a multivariate analysis, increased the overall mortality rates in their group. So the bottom line is that we thought technology actually helps patients when we do minimally invasive radical nephrectomy. We actually overuse radical nephrectomy for those 2 to 4 centimeter tumors. And despite the evidence that we have right now, we continue to do a lot of radical nephrectomies where we actually could do a partial and don't do a partial. And open partial nephrectomy and laparoscopic are hard, and that's why we tend not to do it. There's more complications, a more difficult operation, and we tend to say to the patient, you'll do fine, let's just do a radical. It's wrong. We are telling them the wrong message. This data is not yet in our textbook to our residents, and we should quickly incorporate this. Everybody needs to know that we need to save nephrons. And this is just to show you, again, the lap radical nephrectomy period since '96, that we did not increase the amount of partials as we should have for tumors 2 centimeters to 4 centimeters. Those should have been up here. In the 80% of these patients should have had a partial nephrectomy. So we live in a period of very, very rapid technique change. We go from, when I finished my residency, I thought, I'll do this all my life. Then I went to a fellowship with Ralph Kleiman. I thought, that's what I'll do all my life. This is Ralph Kleiman doing a laparoscopic nephrectomy. And then I'm finding myself now doing partial nephrectomies with a robot. So how did that affect patient care? I think this part on nephrectomy actually did a bad service to the patient. We actually handicapped them. And my hope is that with the robot, which enables us to do nephron sparing surgery better and easier, we'll have a benefit here. And the cons of doing a robotic partial nephrectomy is that the surgeon is more dependent on the assistant. There is a loss of lateral retraction to be done very easily. The cost is significant. However, the pros are that we may provide better outcomes than laparoscopic partial nephrectomy. They are not perfect. I didn't include this here, but the outcomes of partial nephrectomy are not as good as open nephrectomy. And we know now, shorter warm ischemia time, easier excision and suturing, and easy adoption by all surgeons that give it the fair chance of learning it. So it may be, we'll see, it may be related to less complication, may be related to more nephron sparing, and hopefully more patients will enjoy nephron sparing by this method. And this is just a few studies that did the comparison between radical and partial nephrectomy showing that, the robotic and laparoscopic partial nephrectomy showing that the robotic is as good as at least as good as the laparoscopic approach. And multiple studies recently are showing the same things, and now we have a barrage of people trying to have no ischemia and so forth, but the robot is very promising to be able to allow us to provide the patients with a good nephron sparing surgery. And the take-home message is, that to reduce overall mortality in patients with renal cell carcinoma, nephron sparing surgery should be performed whenever technically feasible. And robotic surgery has the potential, I'm not sure yet, but has the potential to become the great equalizer that will allow more surgeons to perform nephron sparing surgery and more patients to enjoy both the benefits of nephron sparing surgery and minimally invasive surgery. And that's the hardcore runners that don't raise money but work really hard. Thank you.